Hi, my name is Samantha Schwartz. My area of study is public health, and I plan to continue my education by getting a master's degree in healthcare administration. My research mentor is Dr. Ara Joe. The research Dr. Joe, her team, and I are conducting is for Ed Jimenez, the CEO of UF Health. Today I will be presenting on a 2003 article entitled Special Healthcare Taxing Districts, Association with Population Health Status. Special healthcare taxing districts were originally developed to fund the construction of facilities and services infrastructure to provide medical care for the poor. Historically, facilities such as public hospitals received a substantial portion of their income from special healthcare taxing districts. Due to alternative methods of healthcare financing, such as managed care organizations, the advisability of local investment in the form of special taxing districts has come under intense scrutiny. Special taxing districts exist in all 67 Florida counties. And of the 67 counties in Florida, 21 counties have no healthcare special district participation at all. Among the counties that do participate, there are extreme disparities between rural counties and more urbanized counties. For example, most urban counties have several healthcare special districts, whereas as many as 3 rural counties may share one. Scutchfeld et al. Determined that certain public health capacity characteristics such as funding, organizational leadership, and the development of partnerships with non-providers were related to process measures of performance as measured by the Centers for Disease Control and Prevention's National Public Health Performance Standard Assessment Instrument. Mays et al. Determined the association of institutional, financial, and community characteristics of local public health delivery systems and the performance of essential services. The existing literature suggests that communities with certain capacities resulting from certain sufficient infrastructure are more likely to perform certain services. The important assumption, of course, is that these infrastructure-driven activities result in measurable improvements in important public health outcomes, such as the reductions in morbidity and mortality. The ultimate value achieved by investment in infrastructure, therefore, will be determined by the extent to which evidence-based program-to-outcome relationships are demonstrated. Health outcomes have been studied on 2 levels. The macro level is concerned with measuring the determinants of health from the perspective of their impact on a population or a community. The micro level examines the impact of efficiency, effectiveness, and equity on health outcomes at the system, organizational, or patient level. Infrastructure is the element that links the micro and macro levels of analysis. One important contributory factor to the development of infrastructure, although largely unstudied, is the local special taxing district. Absent from these discussions has been any comprehensive assessment of the impact of districts on the health outcomes of the communities in which they operate. Although locally generated special healthcare taxes are an important component of community infrastructure, their impact on the health status of the population has not been systematically addressed. Therefore, it's widely unknown. The objectives of this study were to compare the socioeconomic and demographic characteristics of counties that had active special healthcare taxing districts with those counties that had no taxing authority or had the authority but were not exercising it, and to determine whether the active healthcare taxing districts demonstrated a measurable impact on the health status of the populations they serve. For this experimental study, the comparative health status of counties was measured by disease-specific, age-adjusted mortality rates for the leading causes of death in the state. One county was eliminated prior to assignment because it had a small population base, a large state prison system staging facility, and it exceeded the mean by more than 3 standard deviations for many outcomes of interest. In order to be included in the study, the 66 remaining Florida counties had to meet all of the following requirements. 1. The county must have had special healthcare district taxing authority. 2. The county must have used its special healthcare district taxing authority. And 3. The county must have levied taxes for at least 3 years using one of the 3 forms of taxation in the study period. Major data sources that were used include Florida Vital Statistics, hospital discharges, cancer registry, and infectious disease reporting. Even if an association is determined to exist between the investment of tax dollars in healthcare and population health outcomes, other mediating factors can act to differentially influence those outcomes. Counties differ substantially in the level of health resources, population socio-demographics, and environment in which those resources are applied. As a result, all known barriers such as race, ethnicity, rurality, poverty, access to a public hospital, and physician availability were controlled for in the study. The data considered for 66 counties over a 5-year period resulted in 330 observations per variable, providing sufficient power to reveal small to moderate differences using the selected tests. Outcome measures were dichotomized at the county level of analysis based on position relative to the state mean for total and disease-specific age-adjusted mortality rates. The data were stratified on the basis of the county's use of healthcare special taxation, which allowed for the computation of odds ratios and corresponding confidence intervals. On average, taxing district counties had improved economic circumstances and favorable health status relative to the non-taxing counties. In 3 of the cancer indicators, there is a pattern of higher morbidity for the taxing district counties, accompanied by lower mortality for prostate cancer, melanoma, and colorectal cancer. While this pattern requires more detailed scrutiny, one interpretation would suggest that the available resources inside taxing counties were improving access to primary care, case finding, and availability of screening programs, and access to technology, all of which would tend to increase morbidity rates. A related assumption is that bringing more people to care earlier in their illness would reduce death rates, resulting in the reverse pattern for morbidity and mortality. The null value of an odds ratio is 1. Therefore, anything less than 1 is considered a protective factor, while anything greater than 1 is considered a risk factor. The odds ratio is used as a measure of the relative risk of dying depending on whether one lives in a taxing district or a non-taxing district. By analyzing this chart, you should be able to determine that the risk of dying from any cause in a taxing district county is 0.63 of the risk for a person residing in a non-taxing district county. It's also important to note that all 95% confidence intervals are all under 1. Therefore, the odds ratios are all statistically significant. This is evidence for negative association and may be indicative of a protective effect. This analysis provides empirical support for the conclusion that local investment in healthcare, as reflected in local tax transfers to public health and healthcare programs and infrastructure, is associated with improved health status of the population served. The existing literature, Scutchfeld et al. And Mays et al., suggests that communities with certain capacities resulting from sufficient infrastructure are more likely to perform certain services. This study's findings are congruent with the findings of the existing literature. Locally generated tax revenues used for the provision of healthcare services are consistently associated with improved health outcomes of major public health importance. The research I am conducting for my honors thesis surrounds health outcomes and healthcare utilization in Florida through the examination of every county's health outcomes and health rankings. The study's aim is to identify and determine the reasons as to why the health outcomes in counties, sometimes neighboring counties, differ to such extremes. In order to do so, we are investigating factors such as healthcare utilization as well as many others that impact each and every Florida county. Take a look at St. Johns County and Putnam County. They are extremely close in proximity, yet St. Johns County is ranked as number 1 for the state in health outcomes and health factors, whereas Putnam County is ranked dead last as number 67 for health outcomes and health rankings in the state of Florida. Our mission is to explore reasons as to why this is, as well as figure out possible solutions for the communities impacted.